Leukemia, types, diagnosis, and treatments. Leukemia is a group of hematological malignancies that affect blood and bone marrow cells. They are classified based on their progression, acute or chronic, and the type of blood cell affected, lymphocytes or myeloid cells. Classification and diagnosis are based on clinical, histological, cytogenetic, and molecular characteristics. Acute lymphoblastic leukemia, all abnormal proliferation of immature lymphocytes, lymphoblasts. It is more common in children. Acute myeloid leukemia, AML, proliferation of myeloblasts. It mainly affects adults. Chronic lymphocytic leukemia, CLL, it affects mature lymphocytes, especially in elderly patients. Chronic myeloid leukemia, CML, associated with the Philadelphia chromosome, translocation T922, with proliferation of granulocytes. Histological diagnosis requires analysis of bone marrow or peripheral blood. Basic blood tests, complete blood count, leukocytosis or pancytopenia, increased blasts in acute forms, peripheral smear, morphological evaluation of cells. Bone marrow biopsy and aspirate, quantitative and qualitative comparison of bone marrow cellularity. Immunophenotyping, flow cytometry determines specific surface markers to distinguish between various shapes. Cytogenetics and molecular biology. Advanced molecular techniques, PCR and NGS, next-generation sequencing to detect specific genetic mutations. Cerebrospinal fluid analysis, to evaluate central nervous system involvement in acute leukemias. An accurate diagnosis is crucial to determine the appropriate therapy, chemotherapy, immunotherapy, targeted therapy, or bone marrow transplant. The distribution of leukemia varies significantly by type, with some forms more common in children and others predominating in adults or the elderly. Here's a summary based on the type. Acute lymphoblastic leukemia, all main patients, children and adolescents. It is the most common form of pediatric leukemia, accounting for approximately 80% of childhood leukemias. In adult patients, all is less common but can occur, with a generally less favorable prognosis than in children. Acute myeloid leukemia, AML, main patients, adults, especially the elderly, rare in children. It represents less than 15% of pediatric leukemias. Chronic lymphocytic leukemia, CLL, it is rare before the age of 40 and is more common in people over the age of 60, with an average diagnosis around the age of 70. It is the most common chronic leukemia in Western countries, while it is rare in Asia. Chronic myeloid leukemia, CML, main patients, middle-aged adults. It is rare in children and adolescents, with a peak incidence between the ages of 40 and 60. While all is predominant in children, in young adults, 20 to 40 years, mixed prevalence of all and AML, but acute forms are more common than chronic ones. Mature adults, 40 to 60 years, CML and AML become more common. In the elderly, age over 60 years, CLL and AML predominate, with a significant increase in AML. This age distribution reflects the different genetic and biological origins of each type of leukemia. The etiology of leukemia is not fully understood, but it is believed to be multifactorial, including genetic predisposition, environmental exposures, and somatic alterations. Here is a summary of the etiological hypotheses for the main forms of leukemia. Acute lymphoblastic leukemia, all genetic syndromes, Down syndrome, Fanconi anemia, Bloom syndrome, and others increase the risk. Environmental factors, exposure to ionizing radiation, e.g., nuclear accidents or radiation treatments. Viral infections, the double exposure hypothesis in childhood, delayed exposure to common infections may increase risk. Alterations of the immune system, such as in immunosuppressed children. Acute myeloid leukemia, AML, exposure to toxins, previous chemotherapy or radiation, alkylating drugs and topoisomerase inhibitors can cause secondary AML. Exposure to benzene or other organic solvents. Genetic and cytogenetic abnormalities, mutations in genes such as FLT3, NPM1, or SEPA. Myelodysplastic syndrome or other pre-existing conditions, AML, can develop as an evolution of a myeloproliferative disorder or myelodysplasia. Chronic lymphocytic leukemia, CLL, genetic predisposition, familial history, CLL shows a higher incidence in families with a history of leukemia or lymphoma. Genetic alterations, deletions, e.g. 13q, 17p, or mutations in genes such as TP53 and Notch1. Environmental factors, weak relationship with environmental exposures, but some studies suggest a role for pesticides or chemicals. Chronic myeloid leukemia, CML, key genetic alteration, translocation T922, forming the BCR-ABL fusion gene, responsible for the uncontrolled proliferation of myeloid cells. This anomaly is not inherited, but acquired during life. Environmental factors, ionizing radiation, the incidence of CML has been associated with radiation exposure, e.g., Hiroshima/Nagasaki survivors. Genetic factors, accumulation of spontaneous mutations in the DNA of hematopoietic stem cells. Genetic polymorphisms that predispose to errors in DNA repair or immune regulation. Environmental factors, ionizing radiation, detected for all, AML, and CML. Chemical exposure, benzene and pesticides are known risk factors for myeloid leukemias. Infections and the immune system, viral hypothesis, e.g., Epstein-Barr virus, HTLV-1 for T-cell lymphomas/leukemias, in some subtypes, although not universally accepted. Leukemia treatments vary based on the type, the specific subtype, the patient's age, and the presence of genetic or molecular abnormalities. Here's an overview of the main treatment options for each form of leukemia. Acute lymphoblastic leukemia, all-intensive chemotherapy, multi-phase protocol, induction, consolidation, maintenance. Common medications, vincristine, prednisone, L-asparaginase, methotrexate. Targeted therapy, BCR-ABL inhibitors, for Philadelphia-positive, Ph+ forms imatinib, dasatinib, or ponitinib. Monoclonal antibodies, blinatumomab, against CD19, and inotuzumab ozogamicin, against CD22. Hematopoietic stem cell transplantation, HSCT, indicated for high-risk patients or patients refractory to standard therapy. CAR-T therapy, innovative cell therapy with engineered T lymphocytes to target CD19-expressing tumor cells. Acute myeloid leukemia, AML. Treatments and prospects in the cure of leukemia. Standard regimens, e.g., 7+3, combination of cytarabine and daunorubicin. Promyelocytic forms, APL all-trans-retinoic acid, ATRA, plus arsenic trioxide, ATO. FLT3 inhibitors, midostaurin, gilteritinib, IDH1/IDH2 inhibitors, ivosidenib, inacidenib BCL2 inhibitors, venetoclax, often combined with hypomethylating agents. Transfusions, prophylaxis against infections, and treatments for complications, e.g., tumor lysis syndrome. Curative option for young/adult patients with high-risk or recurrent forms. Bruton's tyrosine kinase, BTK, inhibitors, ibrutinib, acalabrutinib, zanubrutinib. BCL2 inhibitors, venetoclax, often combined with monoclonal antibodies. PI3K inhibitors, idelalisib, duvelisib. Rituximab, obinutuzumab, or alemtuzumab to target CD20+ cells. Combinations such as FCR or fludarabine, cyclophosphamide, rituximab, used less frequently thanks to newer drugs. Infectious prophylaxis, transfusions, and palliative treatments for chronic symptoms. Imatinib first generation. Dasatinib, nilotinib, bosutinib second generation. Ponitinib a third generation, for resistant cases. Reserved for patients refractory to TKIs or in blast crisis. Monitoring of the molecular response, reduction of BCR-ABL, to optimize therapy. Transfusions of red blood cells and platelets. antibiotics, antifungals, and antivirals to prevent and treat infections. Management of complications such as tumor lysis syndrome, coagulopathies, or anemia. New options, such as bispecific antibodies or immunomodulators, are under development. Gene therapy, new technologies to correct mutations. Epigenetic inhibitors, to reactivate tumor suppressor genes. Personalized medicine, based on genetic and molecular analyses for tailored therapies. Survival in leukemia depends on the type, stage at diagnosis, patient age, and associated genetic abnormalities. Thanks to advances in treatment, survival rates have improved significantly for many forms of leukemia. Here's an overview. 5-year survival, 85 to 90% thanks to effective chemotherapy protocols and stem cell transplants. Better prognosis for low-risk genetic subtypes, E at G, T, 12, 21, translocation. 5-year survival, 40 to 50%, with lower rates than children. Worse prognosis for Philadelphia-positive, Ph plus I forms, but improved with BCR-ABL inhibitors. 5-year survival, 40 to 50%, with significant variations based on cytogenetic subtype. Favorable prognosis for NPM1 mutations without FLT3 ITD. 5-year survival, 5 to 15%, often due to comorbidities and treatment resistance. 5-year survival, 80 to 90%, thanks to the combination of ATRA and arsenic trioxide. Average survival, 10 to 20 years, thanks to targeted therapies, E at G, BTK and BCL2 inhibitors. Median survival, 3 to 5 years, improved with targeted therapies. Many live long lives without the need for immediate treatment. 5-year survival, 90% or more. Most patients live greater than 20 years, with CML managed as a chronic disease. Genetic abnormalities, alterations such as T9, 22, Philadelphia, worsen the prognosis in all and CML, but respond to TKIs. Age, worse prognosis in elderly patients, often due to comorbidities and lower tolerance to intensive treatments. Response to treatment, patients who achieve early complete remission have better long-term outcomes. Access to advanced therapies, new drugs and transplants have significantly improved survival rates. In Italy, there are numerous centers of excellence specializing in leukemia treatment, with innovative and personalized approaches. Among the main ones are: it is a reference center for the diagnosis and treatment of leukemia, with a focus on personalized medicine. It offers advanced techniques such as genetic sequencing to identify hereditary predispositions and guide therapy. Both are accredited for advanced therapies such as CAR-T, used for patients who don't respond to traditional therapies or who have relapsed. CAR-T genetically alters the patient's T lymphocytes to fight tumor cells. It includes the Regina Margherita Children's Hospital, which is particularly active in the treatment of pediatric leukemia, in collaboration with other regional structures. Centers of excellence for advanced hematological treatments, including CAR-T cell therapies. Renowned for the management and treatment of childhood leukemia. These centers collaborate with national networks, such as those supported by AIL, Italian Association Against Leukemia, which support research, patient care, and training of healthcare professionals. To access treatments, it is essential to contact an expert hematologist who can direct you to the center best suited to your specific therapeutic needs. Thanks for following us this far. If you are interested in health topics, subscribe to the channel for new videos.